Thank you for that. That was an introduction that I have to now. The bar has been set high, but thank you everyone, and apologies to the organisers that they were a bit worried about when I was going to get here. So I do try and get in time, but I'm here. So thank you, and I'm sorry to have missed the first day, but I've just come back from annual leave as well. So, but I have got here, so it's great to be here. So thank you very much. So what I'm going to talk today about is really, I'm going to take you on a slight journey. Probably a lot of people already know some of the issues, but hopefully I've put it in a way that makes sense. And at the start, I'm going to talk a bit about issues or problems, but I never like to leave things hanging like, oh, this is really hard or whatever. So I'm going to give some steps, what I think are steps forward or pathways to actually deliver better services, because that's what we are all about. And so what I've called my presentation is that we're not all the same, where to now. And I'll explain a bit more of that. Now let's see if I get it. Yep, and so as the speaker, I'd like to acknowledge the fact that we're on traditional lands of Indigenous people, lands that were stolen. And being a health conference, I really like to point to the fact that the effects of colonisation and dispossessions have led to really negative health effects that are still being felt today, and that's what we should be aware of why those effects are still happening today. And some of what I'm going to talk are going to address some of those structural issues, and I'd like to pay my respect to any Indigenous people present. So to start off with, I want to give you the overall view of CALD. And what is CALD? Often, everyone uses this term. And it's culturally and linguistically diverse people. But who are we really like? And so this is from the latest census. It's almost half of us have at least one parent born overseas, 48%. Just a quarter of us actually are born overseas ourselves, and another quarter speak a language other than English at home. So this is, what CALD people often refer to. But in reality, is often once you start to try and define it, it becomes a bit tricky with lots of other issues. Now, interestingly, that the ABS, the main statistical organisation in Australia, actually classifies CALD as coming from countries that are non-main English-speaking countries. And interesting, they've put something like South Africa in there as well. And of course, countries like the USA and the UK and New Zealand have actually high proportions of people who are CALD as well. So as you can see, it becomes a bit hard to define. It's actually also was sort of like acronym that's often referred to people who have come from different culture and languages. There was also something that's not used anymore as much, LOTE, speaking languages other than English, which replaced NESB, which is non-English speaking background. So for some of us who are older, we sort of know there are a lot of terms being used, and it's all an attempt to actually get a better term. And of course, I'm actually old enough to have come here where New Australians, migrants were actually called New Australians. And in actual fact, as I've got older, I've actually I didn't like that term, but I actually started to like that term more, because it's sort of like, it just says, well, you're new to the country. It doesn't actually say anything else. And we also, sometimes we fall into the trap of thinking that CALD means outsider, different. And conversely, that Australian born are presumed to be non-CALD and often white. Whatever then white, how you define white is another issue that we won't even go into. So you can see there's a lot of issues, and also CALD is often used to say that CALD are to describe differences, exclusion, instead of, and it's individualized, instead of looking at the wider picture of wider structural framework, and I'm going to come back to that. And so often when you have discussions, people use these terms in different ways, and so it's actually been very hard to know who are you talking about. Because of course, when you're talking about cold, some of us have been here many years. Some of us have been highly educated and skilled, got good paying jobs, are actually rich. That's right, you know. Know many languages on top of English. Have got nice lives, look very mainstream or feel very mainstream, were born in Australia, and again, there's a really big debate whether, how do you call migrants cold, you know, are they born in Australia or not, are young and old and women. So there's a real big difference there. And so what this means from our role as health promotion, as where we work, is these complexities often, and I've had conversation with people that they go, I want to work with cold people. And you go, that's great, but who? And I've actually had people go, oh, that's a good question. Which is interesting because it just seems, oh, you know, cold, it's out there. So these specific communities can be flattened, rendered unclear, invisible by this term. And then we actually don't know, so which program are we actually targeting, which communities, and why? And what lessons can we learn from previous work? And I actually had a conversation about a year ago, I think, that we were approached to do work around healthy relationships, and we were asked to say, oh, well, you're a CALD organisation. I think CALD young people around healthy relationship, there's a problem. And I go, oh, yeah, all right. So which communities are you talking about? Like, and they went, oh no, we want you to tell us that. And you go, well, why are you coming? You've come to us with the problem, and now you're saying you don't even know which community. So why have you even said CALD youth? So these are the issues that we try to bring up. Now, so what now? So I've just talked about, you know, made a few people laugh, and obviously a few people have experienced, encountered this. So where do we go now? Well, unfortunately, I actually don't have any easy answers because the problem is very complex, because it's also really tied up with identity, how people identify themselves. That's a totally different issue. Because of course then people have multi-complex identities, and how one person identifies is not how the other person identifies. But these are all terms that are being used. So we often use migrant refugee background, but that's still very, you know, how many generations do you go back? Diversity, intersectionality, sometimes intersectionality, minorities, inter-ethnic, interracial. There's a new term now coming out, I don't know if people have heard, intercultural. That's actually coming out from Europe, and they want to replace multiculturalism with interculturalism. Again, there's a whole debate about that. But so these are all terms that are trying to give a bit of a view of clarity. But there's not much clarity because it is really hard. So for us, what we are looking at is really we want to say to people, well, go back to old framework. There was already frameworks in public health, in health promotion, that we can use. One of them is the social determinants of health. It's been around quite a long time, and it really became, you know, that term, social determinants of health, really came out in 78 through the Alta Declaration of 1978. So it's been around quite a bit, and it's developed, and I'll get to it a bit further on as well. And also about community development. In other words, community development's been around again many decades, but it's really about a holistic approach about human rights, inclusion, social justice, collective action, self-determination, and has a lot of applications to primary health care. So I really think that we as people working in public health, in health promotion, should really have these two lenses, the social determinants of health and community development of health framework. And the reason is that they really look at the structures, they look at the processes. They are not really focused on the individual, but they look at long term. And so this is the social determinants of health. If people haven't seen them recently, I always encourage people to go back to, because as you can see, basically says that your health outcome, how your health is not really because of you. Your health is really about the society and the community that you live in. And so if you want to improve your health, it's not as easy to say, eat less or do a bit more exercise or be more careful. There's lots of other issues around. I won't actually go into all that. You can see, and interesting, number 7, housing, which in Australia now has become quite a big issue, has actually got all kinds of health ramifications. So really, if I was the Minister of Health, not that I am, but in Australia, if I wanted to improve the health of Australians, the best thing you could do is to give stable housing to everyone. That will be the first thing. That will be the most important thing you do, and everything else would flow from there. But anyway, enough of that. That's and also about, like, then when we talk about migrant and refugee issues, again, I change the words they use, so I'm not perfect. We then have to remember that not only we are, of course we're not all the same, but that people have got all kinds of histories. And so we have to be aware that, you know, we might get a person from a war-torn country, we might get 3 people, one after the other, but each person will have their own story, and how they are able to relate or their conditions will be different. So you have to be aware of things like their experiences, their health beliefs, their backgrounds, financial issues, the racial harassment they've had, lots of things there. I won't. And also, of course, health literacy, often talked about, sometimes forgotten about. Health literacy is actually a two-way street, because it's not, yes, it's good that, I always find that cartoon quite sort of funny, but it's actually true. Like, we actually do use stool as a sample, and, you know, and you go, what the hell is a stool, you know? But in actual fact, I can actually give you a very quick historical background to why stool is used. Does anyone know why stool is used as a metaphor of feces? That's a very good attempt, but it's actually not quite correct. It's actually historical. Stool, because back in the UK, Europe had very good hygiene during the Greeks and the Romans and all that, but then sort of forgot about it. And public health was pretty shit in many ways. And then they rediscovered sewerage. And so for the kings of England and the queens, they actually had the royal stool. They actually had their stool. And so they actually had attendants to take the stool out. And that was actually a very, very important job to do that, because you had a private audience with the king or queen. So it was actually a highly coveted job. So that's actually where the royal stool comes from it. Anyway, we'll get back to it. So what I want to talk about health literacy is about how, so there's both the structural and the individual. And often how we talk about health literacy is about, oh, the person's health literacy needs to improve. They don't know things, which, yes, it's correct. But also the health literacy of the organisation has to improve. And that will actually have much greater long-term outcomes than any kind of trying to work on the individual. And that's really about not assuming that people know what a referral is, making sure that your language and your documents are easy to read, etc., etc. So this is important always to remember in everything that we do. So, how do we translate this into practice? I said I wasn't going to leave you with all the problems. So let's talk about some of the solutions, some of the way forwards. Some of which I'm sure you do it and you know it, so it's fantastic. So don't, I'm not here to tell you what you should be doing. But what I think we need to do as a framework again, let's be clear about identifying the issues, identify clearly the population, community or parts of, because often people talk about, say, oh, we want to work with the Chinese community. Well, the Chinese community in Victoria is one of the biggest, and there's incredible sub-communities in there as well. So what is the problem? What is the issue? And who's defining it? What are the objectives and aims that we are wanting to achieve? What engagement strategies have we got to create that feedback loop? And it was great, the previous presentation from Carolyn, you know, obviously you've got that feedback loop, which is really important. If you don't have it, your project will probably go somewhere else. And ability to change and to be flexible. And we've had that ourselves in our work. You know, we go, this is our idea, we do that, and then you go, it's not working. It's not going to work. So you go, what's your plan B? What's your plan C? What's your plan D? Very important. And what outcomes and what measures? And again, who actually decides those? Is it us or the people, the community involved? That's really, really important. So those are the things that we need to keep in mind. So how do we achieve those? How can we put them in practice? Very important. It shouldn't really be said, but it's very important. We've got to create spaces of trust. When we talk to people, either individually or at a community level, people actually have to trust us. They have to trust that we're actually working with them, not against them. And so people can actually share their beliefs, can share their views, and actually, you know, be able to say, no, I don't believe you. Or I go, no, I actually pray 5 times a day and that will actually heal me. And you've got to, how do you respond to that? How do you engage with that? And, you know, there could be lots of other things. So once people feel they're safe and once people feel they can actually talk to you, then you're actually halfway there. You've actually got that relationship and trust. Time. I know we're all under the pump, but often time is really, really important to sit there, to actually talk to people. And often you have to talk to people for quite a bit about other subjects because they will actually be working out who are you. And actually it's all about getting their trust. So, and it builds knowledge and it capacity and understanding. And so time, never look at, I've only got 5 minutes, or we talked about something else for 10 minutes and we never got to that important bit. Well, you did, because you've developed trust and engagement, and that's important. Who's heard of explanatory models of health? Yep, a few people, yep, good. So, look, these are there's a number of them. So, but basically, what they do, it's basically a tool to simplify. So instead of me going to someone and say, I think you're sick, I think you've got a problem, and I think this is what you should be doing, you actually ask them. You actually get them to tell you, explain why they're here or what the issues are in their own words. And it creates a picture of where they are. So you can actually then intersect with them. And basically it's also called a how, why, what, when model. And as you can, so it's actually relatively simple. It's relatively easy to learn this model. It basically says, you ask people, when do you think this issue first arose? When do you think, how is this affecting you and your family? What do you fear most? And as you can see, by having these words, you're letting the person say in their own words, from their own background, this is other issues, this is what concerns me. And then you'll be going, oh yeah, tick, yes, I know that, yeah, tick, tick, tick. So, and again, it takes time though. I do have to say, this process takes time. Who's worked with interpreters? A lot of people. Yeah, great. Now, there's lots I can say about interpreters, but first of all, briefing is really, really important. If you always, I think that is something that you need to do with interpreters briefing, because the reality is, while interpreters are professional, highly skilled, they're also human. And often when we talk about health, what they are interpreting are actually quite hard situations, sensitive, complex situations. And we have to be aware of that. We can't just assume and expect someone to step into a conversation about terminal cancer scenario. We have to, and this is where the briefing comes into it, where we actually say, hi Pierre, you've come, and I was actually an interpreter many years ago. This is what we're going to talk about. These are the words. This is the scenario. How are you feeling about it? Do you know the words? And and you give time to the interpreters to actually think about it. And you might also have the situation where the interpreter might be, at the end of the day, they've already had 5 in big interpreting session, and you're going to say this is a terminal cancer scenario, and they might just go, I can't do it. It's just too much. And while for you to go, oh, heck, this is going to ruin the concert, whatever, it's actually better to say, no, we won't go through it, than actually have an interpreter that can't handle the situation that you're going to put them through. So, as I said, they're professionals, but they're not machines. AI has not replaced interpreters yet. So they are human beings, and especially then, even debriefing is very important. So that's the only thing. There's lots of other things, but when you do use interpreters, think about they're human beings. The last one, we often forget this. Reflection. Reflect on what we've done. Take time to think of how we've done it, and talk to your colleagues about it. Because there's often more than one way to do things. People will have other ideas, and we will get it wrong. Like, we get it wrong. I get it wrong. And sometimes you go, I can tell you, like, once I tried to set up a scenario-based discussion with a group of people from a community. I thought, great, I'll go in there. I love scenarios, they're great discussions, whatever. These people weren't prepared for the scenarios. We're not prepared to look at the different alternatives. They just went, do that. A person's doing extramarital sex, well, that's their problem, Someone runs away from the family, call the police. No. And I went, oh, because I just assumed. I assumed they were ready for this, and it was my mistake. And so some of the errors that we make are actually the best learning that we can have. But we need time to reflect, and always talk to your colleagues. It's very, very important, because we can always improve. So just to finish up, so in summary, it's really a journey. We need to identify work with specific communities, sub-communities. It's important with that. We need to be clear why we're doing it. We need to work in an anti-racist and inclusive way, because let's face it, marginalisation, oppression, racism is out there. So let's not sweep it under the carpet, but be aware of it. And does anyone know where that picture has come from? Someone has? No? Yes? Anyone has to guess? All right, it's... No, I'm afraid, no, thanks for the guess. It's actually from Chiapas, southern Mexico, the Zapatistas, back in the early 2000s. And the reason I put it there is because they very much had as their slogan, asking as you walk. And in other words, you always doubt yourself. You always ask, and you always see and reflect on what you're doing. So it's very, very important. And be aware of the social, political, economic and cultural environment that you're working in. It's very important because some communities are very marginalised. And don't be afraid. That's because you are going to make mistakes. There are going to be very sensitive issues, but we have to work with communities and we have to work in partnerships. And some problems are very, very difficult to overcome, and it's going to be long term. So just to finish up, more tools to help you. If no one has heard of Health Translations, I highly recommend it. It's got over 24,000 translated pieces of material and keeps growing. The Better Health channel, very often very quick, short information. We have a newsletter at CH and also a cultural and competence health literacy a portal now where you can access for free our webinars. But hopefully you'll be able to get these slides. Yep, good. So I finished. Any questions? I don't know if I haven't got